You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome back to CRST, the podcast. I'm Cathleen McCabe, Chief Medical Editor for CRST and your host for today's episode. In our January 2026 issue, the cover focus tackles a very right now problem. AI is already embedded in imaging, measurements, planning, and counseling. So the question is no longer whether it will influence our decisions, but how we integrate these tools responsibly in everyday practice. One of the pieces in this cover focus is AI Beyond the Clinic by Dr. Campton and by Dr. Sean Ianchulev, which looks at how regulation and reimbursement are accelerating AI and home monitoring beyond our exam lanes into patients' homes and our practice operations. Joining me today is Dr. Sean Ianchulev. He is the co-author of AI Beyond the Clinic, and he's going to help us to translate these policies and payment shifts into practical decision-making for ophthalmology. So I'm super excited about this topic, and I'm really glad to have you here, Sean, to help shed some light into something that, I don't know, I think people are a little overwhelmed with. At least I know I am when I think about AI and all of the things and ways that it's accelerating change, not just in ophthalmology, but in our daily lives. And I think about what's happening in the future as far as education even and what those skills we need within medicine. AI is going to change all of that. So this is another way that AI is impacting how we provide and elevate patient care. So can you tell us briefly about your roles and where AI currently touches your clinic and your work and innovation, helping us to elevate patient care?
Well, Kathy, thank you. Thank you for inviting me here. And I definitely don't consider myself an expert on AI, although I've been fortunate enough to be involved in a couple of AI projects. I don't think any of us are really experts in that field, which actually is very democratizing because we're kind of on the same, it happened so quickly upon us that nobody was really prepared. And we're all kind of on the same ground here, on the same level. And you can see how quickly things are unfolding. Where I think it's really interesting being involved in academia and training, it really is impacting our residents and medical students. I mean, I work with some of the medical students at the Icahn School of Medicine and our residency program here, the residents, and they are really, really thinking about it, which is scary because some of them are really thinking about what the impact will be on their practice. Actually, a little nugget here. It was interesting when we did our fellowship interviews at New York Eye and Ear. One of the questions I asked all of the fellows interviewing is how often they use AI during the day. And the answer was amazing to all of us who were interviewing them. Probably 80% of them said not at all during the day. So that was scary. But then at the same time, they're so interested in it. So it's kind of interesting how people are dealing with this. I think the medical students...
that answer is different next year.
Yes, I hope so.
That quickly.
Because we felt like all of our faculty, we felt like AI junkies. I mean, we were using it all the time, probably 50 times a day. So it was really fascinating how this was how this is happening. And I think I'm involved with a lot of conversations from those residents and also from the medical students, because they always now look to do something innovative. They love innovation. They want to be involved. But we really don't give them the tools. Nothing in medical school quite yet prepares doctors to do that. And I think some schools are starting to think about that seriously, because we cannot spend a whole year doing anatomy and physiology the way we did it 20 years ago, when everything is in the palm of your hand. So it's really fascinating. You asked me about my involvement. And so I thought a little bit about, first, thank you for inviting me to write that with Dr. Campton. And which was really interesting because it made me think. When you're doing things, sometimes you're not thinking about them, you're doing them and you're flying at 100 miles an hour. And then I realized that, boy, I've been already involved a little bit too deep in AI, and I didn't really appreciate it myself. And I didn't retrospect and really think about it introspectively, what it meant. And I went back and I thought, well, when did I first deal with big data and with data? And when I realized that, it was almost 18, 20 years ago. And that was in the context of a technology that we developed called the Aura, intraoperative vibrometry. And I think you've probably used the Aura, right? And there was an interesting feature about the Aura. And it's actually one of the first technologies that sent data to the cloud. There was nothing that sent data to the cloud back in the days. And I remember how painful it was to convince and to actually execute on that. Because we were aggregating all of the IOL calculations in the cloud. At the time, hospitals barely had Wi-Fi systems, right? So there wasn't like it was a given. There was no 5G. So,
Once again, you were on the cutting edge,
well, we did something
already
very,
understanding the
yeah,
power of big data sets.
yeah.
So, which
And
we
it was a
now
it
really
was a
believe.
powerful, yeah, it
Yeah.
was a powerful data set because we published then with David Chang back in the days the aggregate data, which we have 10,000 or 20,000 data points. So it's all really now coming together. I look at that now, and you ask me what I've been involved in more recently. I've been involved with a technology that recently got approved, and it's been a 5-year track, and it's one of the probably more uh, complex and kind of on the higher end of AI technologies, which requires FDA approval. And we can talk about it. We covered in the paper which technologies actually are exempt from FDA regulation and which are not. And I think that's really important. It so happened that knowing me, I always Velcro into the more difficult innovation technologies. And and so I joined. I was been involved almost for 5 years with a company called AI Health, and they just got approval about a year ago. Actually, several approvals. One is for autonomous diagnosis of diabetic retinopathy with a simple non-mydriatic image, and then we got a second approval with a handheld camera. And all of that went through clinical validation and 5 years of clinical trials. And that's in the category of autonomous diagnostics. So that's one technology.
Right. So that's so interesting to me because, I've been around a while as well. And I remember being a resident and in the VA, and there was so much interest in doing, fundus photography for diabetics as a screening tool. And then, who was going to read all of those once we had all those images? And so, the thought that you need to have sort of a more objective way of screening mass populations not to miss the opportunity to intervene has been around for a long time. And it's funny that it's taken, or maybe I don't know, that's just the cycle of things, but it's taken so long before we really had something that wasn't so burdensome in needing to have human input the entire time to really just identify patients who had the greatest need. And then of course humans can then intervene either by having a patient come in or even reviewing themselves the images that are being flagged. So it's interesting to me how long these cycles sometimes are, and maybe software doesn't always catch up to the idea quite as quickly. You know,
Well, we're so impatient. And so you're absolutely right. The first system for autonomous diabetic retinopathy diagnosis was not ours, was a company called IDX. And that was in 2018. So that's about 6 years ago. And it really hasn't made a footprint very much. I mean, it really opened up the whole AI, and it was revolutionary in the way it came together, and it really opened up reimbursement because actually, as more on the business side, I divide things whether they're AI or reimbursable AI. There's a
well,
pretty
tell
big
us the
difference. Uh,
difference between those two because that's a really important point.
it's a
And in
hugely
the
important,
article,
yeah.
you make the point that if something is not reimbursable, then it's really hard for that to gain traction and be
Yeah, I think it's
adoptable.
hugely important, and kudos to all the people who worked really hard to actually get a code for diabetic retinopathy diagnosis, which pays more to be done by AI than to be done by a human being. So it's and justifiably so because the AI now is almost exceeding that. So sometimes you can do many things with AI. I mean, you can have AI read a chest X-ray, right, or an MRI, and it can do a great job. But if there is no reimbursement for it, then it just becomes a nice tool that helps the doctor be better, maybe more efficient, but
It's
not
hard to get
really to be.
widespread adoption, though, without a way to justify the expense of implementing something because there's there's always an expense, right, to having some new technology, new workflow, new work streams, new ways of educating your staff to make something happen. So there has to be some sort of offset to that. So tell us what's different now about the FDA approval and unique codes for AI. What's different from that now?
Yeah. So yeah, I think a lot has changed. Maybe thanks to COVID, maybe thanks to technology catching up. Again, and it's not just the codes, because I think we doctors are not an easy customer, and as much as sometimes we we have some bad apples and people can read about them, most of us really embrace new technology if it's clinically meaningful. It's not because of necessarily only the reimbursement code. And and diabetic retinopathy is an example for that. I mean, there has been a reimbursement for it since 2018 or 20, but the first technologies didn't really catch on, and you can see why. I mean, some of them did require a significant number of patients to be dilated, almost 20 to 30%. Now, if every fourth and fifth patient has to be dilated, this is not a device you can put in the primary care office, right? And then it really hampers its clinical utility and throughput. So that's one of the reasons why I think on the clinical side the technologies weren't quite there. With AI health, I think one of the great things is we brought that rate down to 3%. And so now when you so there's a big difference. Every 30 or 40 patients you may need to dilate, which actually, if you're in the primary care setting, the need for dilation means the need to send the patient home or to send them to a right. It's not just, oh, I'll put eye drops
Right. So
in the primary
3%
care.
get referred just because they don't dilate, in other words.
Exactly. So I think that was really kind of demonstrative of why some of these technologies don't catch up or catch up. Obviously, it's great to have a reimbursement. That's your oxygen, but then you need octane, which is in the fuel, which is the actual clinical utility and deployment of the technology. So diabetic retinopathy is a great case in point. It's a high bar for AI, meaning you have to be validated. It's an autonomous decision support. It's not an extension, and it falls under the regulated FDA category. So you need to go and do clinical studies, which we did for 5 years, and prove the clinical utility. And in 2022, the FDA came out with the guidance of really the first guidance on AI. And then subsequently in 25, they reinforced that about what really requires regulatory oversight and registration and what doesn't. And it's really important because that really determines how you develop those, and whether you put something and you develop it through the regulatory path, which would take 6-7 years, or you put it through on the market. And I keep saying, if the iPhone was a medical device, we'll be probably on iPhone 2, not on iPhone
That's right.
17.
Yeah, harder to innovate with the cycles you're talking about. But so tell me, I know, diabetic retinopathy was a great place to start because you can take a single image at a single time point and make decisions about that. But there are more complex diseases that we're now looking at remotely monitoring and using AI to help us with decision making that really depend more on serial testing and progression. So what are some of those disease processes and how is that changing how we monitor those patients?
Right. So there is actually so before I go to the monitoring, I want to cover another category, which is again in the clinic. So you have the clinic part, which is where you do the um, uh, regulated pathway, like the diabetic retinopathy, where you're diagnosing disease, you're diagnosing pathology, you're autonomously um, making clinical decisions and clinical
Triaging
diagnosis and
patients
triage.
autonomously. Yeah.
But then you could do things like Harmony, for example, or some of the OCT tools and widgets and gadgets now that give you a little better way of looking at the retina. Those are not making a diagnosis; they're still in the clinic. So those are really framed under the category of clinical decision support for the physician, and so those are exempt, which is great, right? Because
So
you
that's
don't
like
have.
Zeiss Forum or anything that looks at your old your last OCT and compares it to the current one and looks for progression. Is that right or no?
Right. It's exactly that. Or some of the newer ones, Retinai from Essilor, Luxottica now, or Altris AI, or RetinSight. Some of those really very often fall under the lesser kind of category of you don't necessarily need a very, and again, some of these things start to blur. So then if you're really uncertain, you have to go and get a determination from the FDA. But of course, being practical, if you can avoid major regulatory path, try to do that. And so that's one. The other part, which is completely different and it's really exciting, and it's completely new to ophthalmology. We're kind of probably the last specialties to adopt or embrace it, is remote monitoring and principal care management, or under the kind of category of care continuity. And this is actually another company I co-founded with Peter Pham probably 4 or 5 years ago, and it's very interesting. We're just now growing the service. We've done about 150,000 monitoring encounters, and it's a field that is exploding everywhere else. So if you look at your cardiologist, oncologist, so basically for all of these chronic disease patients, which are caught in this very inefficient quagmire of transactional episodic care that we have, it fails them completely, and nobody can connect the dots. You have multiple specialties, and you have patients who are living with a chronic disease, and now we can monitor them. Now we can really comprehensively address their care, but we don't have the ability to do so because our practices are drowning in overhead. Our practices are drowning in trying to staff the lanes, right? So Medicare, and so it started with the payers, really. And they said, listen, it's time to connect the dots for all these people. And they're seeing we're aging population, and the proportion of chronic disease now is much bigger than what it was 50 years ago.
So let me stop you for a second because I want to understand exactly what you're saying. So in cardiology, when my mom is diagnosed with AFib, and then she needs a monitor that goes home with her for a while and then communicates back to her cardiologist, is that the kind of remote monitoring that cardiology has been involved in?
Yeah, exactly. And it could be many other things for diabetes too, where they can monitor. Now you can put your sensor, and some patients will monitor their diabetes. I was on a monitor once when my cardiologist said, well, you turned so and so, and I had some minor flutter, and said, well, let's see what's happening. So they put me for a month on these patches. And again, that is a fundamental new track by Medicare and all the insurance companies. And you and you're involved in innovation all the time. And when you have a new widget or a new gadget, you start out on the typical category 3 T codes and kind of move through that for 10 years. The payers actually outright introduce category 1 codes, and they're global for all of medicine. And they're way beyond ophthalmology.
Compared to the pathways we normally have. Just to
absolutely.
ground that. Yeah.
And it's kind of amazing that they did that. It wasn't kind of experimental, let's dip our toes. And so it's happening everywhere, including orthopedics, rehab right after surgery, or people with arthritis, oncology, rheumatology. So who is it for? It is for everybody who has a chronic condition that requires clinically meaningful monitoring. Right, so that's really important, and there's certain criteria, and you cannot do it lackadaisically or cavalier, because you cannot just give them the device. It has to meet some very good criteria, because if you get audited, even if you did it, if you don't meet the criteria, we know what happens. You're not going to get paid, or they're going to get a clawback.
And just give somebody a device and it's out there monitoring, but you're not monitoring the output, and you're not intervening when necessary, and you don't provide that clinical support, I'm sure. So there's a whole structure that has to be around this in order to make it meaningful. It's just not monitoring to monitor. It's monitoring to intervene.
And the thing is, it's very important because it completely transforms the transactional episodic care paradigm we're used to. I mean, for example, we in glaucoma, we do visual fields, and you're afraid to do 2 in 6 months because maybe the insurance will say, why do you do that? And we had some obviously guidances about how often you can do visual fields, right? Well, here it's the opposite. Patients can test every day. I mean, when they go on the Remoni platform, they test any day, anytime, 24/7. And because the disease is with them, if their disease is not stable or they continue to have it and have a threat to their vision, they can be there for a lifetime. So if you think about it, if we ever talked about patient engagement and staying connected to the patients, this is like the most beautiful thing, because you're connected to them. You're not just doing it when they're in your chair for 3-5 minutes. And today, our touch with the patient is very episodic and ephemeral. We see them for 5 minutes and they're gone. So now you can actually connect to them, ease their entire anxiety, and they feel connected and engaged and cared. And we have seen incredible patient responses and satisfaction with the doctors, even though they don't communicate with the doctors. But again, like you said, it's not just the technology where you give them the device. They're coaches. They have to have somebody talk with them every
Interpret
month,
the
sometimes every
results and
work, interpret the results. And the other thing is that's monitoring. But there is another thing that's more recent, and it's completely, I think, occultly invisible in our field. It's called PCM. And PCM stands for Principal Care Management. And so you probably have heard about chronic care management, where chronic care means people with at least, I think, 3, 4, 5 diseases, your renal failure, diabetes. Of course, we can never manage this kind of complexity in our field. But people realize, and payers realize, that specialty care is very complex too. And so now they have principal care management, where any patient with a single chronic disease is now eligible for disease management and chronic care assistance. For example, we saw what happened with Good Days in retina when they cut off all the assistance for the intravitreal injections, which was in the billions of dollars, and many patients suddenly, the floor fell off and they couldn't pay for that. And all of that care, support, assistive care, assistance with their reimbursement, finding alternative sources, was weighing very heavily on the practices. We in New York Pioneer were getting calls all the time. Everybody was upset and anxious. All that is overhead. All that is frustration, and all that is something we're not equipped to handle. Well, that's where principal care management can do. It's almost like a concierge service for those patients, but it's meaningful concierge service. So that's one of the modules we added, and that's going to be greatly helped by AI, because that would move very quickly to agentic assistive care. And we're preparing to launch.
Explain agentic. We hear the word agentic all the time now, associated with artificial intelligence. So what does the agentic part of it mean?
Yeah, when I first heard it, I said, what is that? I said, everybody wants an agent if you're in Hollywood, when I lived in LA. Right. So that's kind of cool, right? It's nice to have one. Well, I think it's basically having an assistant, an intelligent assistant, and somebody that will help you. It's basically an agent for you, or an agent for the practice that is there. It's kind of the next level of call center with a mind, or with an intelligence.
So it can take various points of input and various frequencies of data acquisition, and you can set it up so it can follow rules that help it to make decisions on individual patients. So it's sort of like having your AI nurse or patient care coordinator who's sort of putting all the data together and helping make decisions, is my understanding. Does that?
Yeah, absolutely. Right? And frankly, we haven't quite seen it yet in our practices. Remoni is rolling it out in about 3 months, a very specific one that would ingest all your practice patterns and then would represent you. So for example, I'm sure you have patients all the time that ask you the same question over and over. Where do I come for my cataract surgery? What do I do on the night before? Or,
right.
And
they call my team, my team handles that. But instead of having to have my staff who have lots of other responsibilities to do, this can step in and sort of be an electronic staff member that helps with that part of it.
Exactly. But it's very important, because that agent can learn, and that agent will be consistent. I'm sure sometimes your staff is tired, sometimes they have a bad day, or somebody is not trained. Imagine this could be at a very different level. And so I think RPM, remote physiologic monitoring, with PCM is all about technology, but it's also meaningfully directed and adapted to a high clinical utility for the patient. And I'm a public health person because when I did my medical training, I also did an MPH, and one of the things about public health I've always loved, and I haven't had that much time spending on that, was the fact that it's population health. Whatever you do, the impact could be really experienced with millions of people if you do something. And so I really like this the age, and I'm directing a lot more attention on my side, not just developing drugs and devices and widgets and gadgets as we know it, but really from product innovation to process innovation. And now the process innovation can get totally hyperscaled with the tools that we have. The fact that we have AI and the fact that we have terminal receptors. And your terminal receptors is your technology, right? Your scanners or whatever that it's with the patient's hands. So I think brace up is going to be a very interesting time. I think there is a perfect fusion of technology, the receptors, the conduit, the cloud, the AI, the agentic part, which really can do this in a very scalable way, and then the reimbursement paradigm, which can enable it. And now the regulatory guidance is clear. So it could not be better time to really think about how we can change the process of care, and how we as physicians who are toiling in the trenches and have no time to lift up our noses from the grinders. And I really hope we do, because we should be the ones driving that bus, not the ones that will be dragged into this, because we can make it clinically meaningful to the patients.
Yeah, I think so. I think the exciting thing is we're developing systems using AI and other tools that use technology, but in a way that's maybe not so capital cost heavy, or set technology that you need to send to the patient and have them use at home. Because a lot of, at least with Ramoni, the testing is even done remotely through devices that the patient already has with specific software. Is that correct?
Yeah. So for some devices, you can do that. So all of our macular function testing, we're using a multimodal technology which does visual acuity, dynamic Amsler grid with photoreceptor bleach testing and registration, kind of the next gen of the Amsler grid, which we know is great, but sits on the fridge and nobody looks at it. But that's all digital and now enhanced. And then we have hyperacuity perimetry, which now can register and so we just had a patient the other day. We have that pretty much every day now. Patients, we flag them, we find out they have a problem, send them to the doctor, they get injected and treated months before they have to. And patients are incredibly thankful. And we're seeing very low rate of false positives. And why is that? Well, the reason it is, all of these devices, for example, many of them are digital, they don't break, so you can do updates very quickly. Not for everything. I mean, too bad we glaucoma guys are always stuck with the more difficult tech.
Yep.
Eye care tonometer.
Sure. Yep.
Yeah, I wish the eye care tonometer was digital. It's not. But that being said, when we do this, we're finding out that patients are extremely, extremely thankful, and we're seeing very low rates of false positive. People are like, wow, all these little artifacts and everything else, but they all become completely melt away because you can tell the patient, oh, there's something here, go back and retest. They can do it in 5 minutes. They can do it tomorrow again. We've seen patients test the wrong eye and they say, oh, my eye changed. Well, of course, that was the left one. You're just not testing the right one. And then the coaches talk to the patients and they have a very warm touch and they know what's going on. So we're seeing very low, and we're actually publishing now the data from the first population health study on remote monitoring, RPM and PCM combined with the coaches and assistive care. Hopefully we'll get it out in the next 2 months. But to me, that's really a great paradigm. If the technology is virtual, even better, if we can do that. And you can have I think many of us doctors develop little apps, and I mean, maybe those become a little more productized. Not every technology, even though ours has to be FDA registered. There are some exceptions, but they have to be a medical device, even though So the CMS has a slightly interesting position on that. So it's not completely overlapping to the FDA. But that being said, it's great times for RPM, PCM, great times for autonomous diagnosis. We'll see that in retina coming. I think that for medical practice, ophthalmologists and anybody in general, it's going to be interesting, because if you're just medical, just like I know there's a lot of medical retina, God bless all the intravitreal injections, fine. But I think at some point all the medical stuff will be taken care of by autonomous diagnosis very easy, which would really make it accessible to all of them. So in the future, I see general practitioners or general, not so specialized people. I think we've seen the last 50 years becoming overly specialized. I think that's going to be unwound over the next 10, 15 years, where you have less specialization because the AI tools will allow you to do that extended assessment, that you no longer need a subspecialist, at least for the medical diagnostic kind of specialties or subspecialties.
Well, I think you're absolutely right. AI is changing everything in the way we look at things. From where you started when you talked about medical education, in the past it was all about knowing the data. Now it's knowing the questions to ask and being able to analyze the outcomes. And that's where the new skills are. And then I think even on the patient side, we were always driving all the testing. I think you're right. There's going to be some of our patients who want to test themselves every single day. And part of what our job is going to be is let's make the patients more reasonable in how they approach this sort of thing, so that they're not, obsessively retesting themselves either. We'll have some of those instead of the ones who forget to come in for their appointment. And I'm excited about this. But once again, Sean, you are at the cutting edge. You're moving the ball forward before we even see that there's a new goalpost out there. So thanks for always thinking ahead and helping us to elevate the care we have for our patients.
I don't feel like I'm very thoughtful about it. I just have a hard time saying no, and somebody pulls me in that direction, and then suddenly I end up going into that rabbit hole. But I would say thank you for kind of doing those podcasts, and I hope all of them really it's a wake-up call for all of us, because right now I'm seeing a lot of us are so busy. Things in the lanes have become incredibly high volume. Everything is about efficiency, private equity, and we really don't have the time. And I again, I'm kind of privileged that I'm not on that treadmill, but all of us who are, it's very little, and people are running out of oxygen to innovate. But now is the time to innovate. Ironically, as hard as it is for us, there's no better time to innovate.
Well, again, thanks for all you do for us and helping us to maybe get disentangled a little bit from the diagnostic side, even the interpretive side. And as you said, the real skill is still going to be on the surgical side, procedure side, where at least not yet, robots can't take our place.
Next time I'll tell you about the robotics company.
Oh, yeah. I said at least not yet. Save some for the next podcast. Join us again. So for our listeners who want to go deeper, you can read AI Beyond the Clinic in the January 2026 issue of CRST, and it's available now at crsttoday.com. And thank you so much, everyone, for listening to this episode of CRST, the podcast. I, as always, learned so much from Sean. So thanks for joining us.
For more shows like the one you just listened to, check out the podcast channel on itube.net.